Hello, everyone, and welcome to this latest edition of the Systems for Action Research in Progress webinar series. My name is Anna Hoover. I am co-director of the Systems for Action National Program Office here at the University of Kentucky, and it is my pleasure to be your moderator for the next hour for a very exciting and interesting conversation about some research being funded by the Robert Wood Johnson Foundation through its Systems for Action program. Systems for Action, as many of you know, is a program that really looks at generating knowledge about how to better align the financing and delivery systems that create a culture of health. In that research portfolio, ever since the first research agenda was created, we have explicitly required all of our funded research to be in some way stakeholder engaged, because as you can imagine, aligning those systems, those various systems, requires the engagement of a variety of stakeholders across a variety of sectors. And while we do foster stakeholder engaged research through the program, it's not every day that we have a community-based participatory research project. That community engaged, stakeholder engaged to CBPR spectrum runs quite wide. So we're very excited today to be talking about some community-based participatory research being conducted out of Texas A&M with the Cheyenne River Sioux in South Dakota. So we will just go through a few housekeeping items here. I'll do some introductions and then we will get underway. First and foremost, I would like to advise you all to find the chat box on your screen, because that is the way in which you will be able to submit questions. And I feel we're going to have a lot of really good and engaged discussion a little later in this presentation. So I really hope that you will use that chat box as we go through the presentation. Write down the questions as they occur to you so that you don't lose them by the end of the call. Today we are going to be hearing from the team that is leading the research on the academic side for this project on the Tasina Luta, or red blanket. Leading this work is Barbara Quiram, who is a professor in the Department of Health Policy and Management and the director of both the Office of Special Programs and Global Health and the USA Center for Rural Public Health Preparedness at the Texas A&M School of Public Health. Preparedness centers during the past 10 years. She has led the team in the work being conducted in South Dakota with the Sioux tribes. Mostly today, however, we're going to be hearing from her colleague, Dr. David Washburn, who is an assistant professor in the Department of Health Policy and Management at the Texas A&M School of Public Health. He received his master's and doctoral degrees from the Harvard School of Public Health. His research interests focus on the interaction between individuals and health systems and include access to care, patient engagement, policy implementation, and global health. Prior to joining the faculty at Texas A&M, Dr. Washburn worked as a strategic planner for the San Francisco VA Medical Center and Stanford Healthcare. He also served in the Peace Corps in Honduras. And with that introduction, I will hand the controls over to Dr. Washburn to talk more about this research. We'll talk a little bit later about our commentator, Alexandra Little.
All right. Thank you so very much for that introduction.
Dr. Washburn, you may be on mute.
Oh, can you hear me now? Oops, hello?
Hello? Yes, I can hear you. I can hear you, Dr. Washburn. Anna, can you hear?
Dr. Washburn, if you're speaking, I think you may be on mute. Could you check your phone to see if you're muted?
I should be off mute now. Are others able to hear me still?
Yes, I can hear you.
Okay. Well, thank you very much for that introduction. It is a great pleasure to be here. We are grateful for this opportunity to work with Systems for Action and the Robert Wood Johnson Foundation on this project. There's another title for this project, sort of the original research title is, as you see before you, Weaving the Tasina Luta, a community-based participatory research approach to implementation and engagement with the tribal public health plan. I just wanted to go over a few of other collaborators that are sort of key components of this research. First, Margaret or Peggy Bag Warrior of the Cheyenne River Sioux Tribe, which I'll also refer to in these slides under the acronym CRST, for brevity purposes. She is sort of the lead author and the developer of the Tasina Luta Public Health Program, a tribe member who lives on the reservation in South Dakota. Harold Tiger is sort of a key public health and emergency preparedness figure for the tribe, who also has lived on the reservation for pretty much the vast majority of his life. Kay Carpenter, a member of the research team who has worked extensively with the CRST in South Dakota for, I think, approximately 12 years. With Brandy Sebasta and Barbara Quiram on those projects, and then there I am as the last collaborator and the presenter for today. Just briefly, an overview of the presentation today. We'll first describe a little bit about what the health program is. I'll give you some background, particularly on the Cheyenne tribe and sort of where they're located in South Dakota and some of the issues that they face. I'll discuss our methods and then some preliminary results, since this is still an ongoing research project. We have done most of our data collection, but also with some quotes in the field. This is largely a qualitative project, and so I'll read you some of the quotes that we've pulled thus far. And then I'll discuss it. And very hope you go with this. Okay, so the Tasina Luta Public Health Program has 4 pillars. This is a tribal-based, tribe-developed. Peggy Bag wrote the Tasina Luta, and it is 4 pillars are having every tribe member on the reservation have an annual health. That is not happening. Providing health-wise handbooks, sort of a guide for every. Be able to engage with their own health. To create a 24-hour Ask a Nurse hotline where people can call in and ask questions about their.
David,
hello?
I'm very sorry to interrupt. We're having some issues with audio breaking in and out. I'm wondering if you are on speakerphone, if you might try speaking into your handset just to see if that helps us at all. Please.
I'm not on speakerphone. Let's see. Perhaps
well, I know our folks are trying. Yeah, our folks are trying to resolve the technical. Please do. I was just thinking that might provide one potential option for trying to improve the audio. But if you're not on speakerphone, then please proceed. Thanks.
Okay. Let's see. Perhaps I could try to switch phones and call in again. Would that be better? Would that potentially help? Or should I just go ahead?
I'm going to ask our technical staff if are you on a cell phone at present?
I am on a cell phone.
That might help, but I need to check in with our technical crew here to make sure that we don't lose you. Kara, will that work? If we try to hang up and dial in on a landline, please?
Well, I would actually just be trying a different cell phone.
Oh, a different cell phone? Okay, well then
that might have
please continue. Yeah, I think the cell phone is, please continue. Thanks.
Okay. My apologies. So I think I was talking about the 24-hour Ask a Nurse hotline, and then the final pillar, the 4th pillar of the Tasina Luta, is an annual health summit of all providers sort of on and around the reservation gathering to try to really build sort of a more collaborative network for providers that really are working with tribe members on a daily basis. Right now there's some sort of barriers between the different services that tribe members make use of. And this is really, the Tasina Luta is really a program about providing better access, but also encouraging greater engagement with tribe members in engaging with public health professionals and providers in and around the reservation much more than they have been sort of doing in the past. And then of course building those collaborative networks between providers that right now do not communicate perhaps as well as they potentially could. So how did this all sort of start? As I mentioned before, the Tasina Luta was developed by Margaret Badwarrior and signed off on as a new initiative by the Cheyenne River Sioux Tribal Health Council. Tribal Health asked the Texas A&M team, or some members of the Texas A&M team, to help facilitate the first annual health summit in 2017 after A&M researchers had been working with CRST on public health and emergency preparedness for about 12 years. And A&M offered to help participate with, or to help with a collaborative community-based participatory research effort in order to assist in the early implementation efforts of the Tasina Luta. All right, and here a little bit of background. So many of you may have seen this map before, and this is a map of life expectancy at birth by county across the United States, both sexes, from 2014. And if you can see that little red circle there, those two counties that are circled, and I'll zoom in the later slides, you can see a little bit more closely. That's where the Cheyenne River Sioux Tribe is located. And when you look across the United States, the darker red, you're seeing life expectancies that are much lower than you do in other places like sort of central Colorado, potentially in the Bay Area, other places in the Northeast and Midwest. And a lot of those very sort of dark red spots in the Dakotas are Indian reservations. So the two counties, there are only two on the Cheyenne River Sioux Tribe Reservation. They had life expectancy rates of 71.02, that's Dewey County. That's the 12th lowest life expectancy for a county in the United States. And 76.39 in Ziebach County, which is the other county on the reservation, which has the second lowest per capita income in the continental United States. So we're really talking about very low life expectancy and endemic poverty on this reservation. Both are much lower than the U.S. average that you can see there. And Dewey County's life expectancy, which is the 12th lowest in the United States, falls between Turkmenistan and North Korea for sort of an international benchmark. So zooming into South Dakota here, those are the two counties of the Cheyenne River Sioux Tribe Reservation. The Cheyenne River Sioux Tribe has a population of approximately 8,000 individuals. While that's not a very big number in total size, it's actually the reservation is slightly smaller in land area than the state of Connecticut. So as you might imagine, this is a very large rural area where travel distances between individuals and providers can be quite vast. Eagle Butte, which is in the middle of the reservation that you can see there, is the administrative center where it's the largest population center on the reservation with approximately 1,350 individuals. That's also the location of where the IHS hospital is. Tribal Health is located largely in Eagle Butte, but it also has outreach clinics across the reservation in a few locations. There are private providers, which are primarily located sort of in and around Eagle Butte. And then larger hospitals exist in Rapid City, Pierre, South Dakota, and Bismarck, North Dakota. And many of those are a few hours away from the reservation. So our research focus was really aimed at gathering information from local experts and tribe members regarding strategies for the implementation of the CRST's first locally driven public health plan, the Tasina Luta. It's a community-based participatory research model where community members provide guidance for the implementation of the plan. And the A&M team is primarily responsible for gathering market research to really help push implementation forward. So a little bit about our methods. There were sort of two primary methods. The first is on this page here. We did 14 key stakeholder interviews, approximately 1 hour each, with community leaders and public health professionals. We covered a variety of issues, including critical success factors for program implementation, effective marketing and promotion methods, how individuals might prioritize the different implementation efforts or the different pillars of the Tasina Luta Public Health Plan, and also how to encourage individuals to engage with the program. Engagement is an issue that is a challenge on the reservation. We also conducted 5 focus groups, 4 of them with community members and 1 with community health representatives who are like community health workers. For those of you that have experience working with tribes, CHRs are prevalent throughout reservations across across the country. Each of those focus groups lasted approximately 1 hour. And we covered many of the same issues as we did in the key stakeholder interviews, and really tried to focus on outreach methods that would work for individuals, why and when they might choose to access medical care, and how they might encourage themselves or others to really become more involved in their own health, and what are some of the barriers that they commonly encounter when they're trying to access health care. We conducted those focus groups in these 4 locations. One of the focus groups in Eagle Butte was with the community health representatives, which is, as that's the administrative center, that's where many of them are located, although they travel out to, they're supposed to travel out to all of the sort of outlying communities. And you see we tried to cast sort of a wide net across the reservation and get some geographic diversity. And these communities are varying sizes. Bridger in the southwest is a very small community, whereas Dupree and Eagle Butte are a little bit larger. Whitehorse is also one of these smaller, sort of more rural communities. All right, so moving on from sort of preliminary themes and results that we found through our conversation. The first theme I want to discuss was getting people to access care before it's too late is a problem. And I'll just read through some of these quotes. I'll probably actually be doing a lot of reading since we are doing qualitative research and we're still doing much of this analysis, getting some of the raw data here. So where I work, there are a lot that disregard their health, even if there is a pre-existing medical condition, and they cover it up with alcohol and drugs. So by the time they do decide to sober up, it's already in a bad stage. We don't get them here until, like I said, middle 3/4 or end stage of the sclerosis. Another quote is, we have a huge no-show rate on just our diabetics that need to come every 3 months, or our cardiac patients that need to come every 6 months to a year, depending on what they're for, their annual EKG or whatever. It's not easy to get people into their appointments. Another theme that we heard a lot of that I kind of alluded to before, which is why it's very important that we try to get a lot of the providers to begin engaging with each other more than they perhaps have in the past, are the divisions between the different health systems that tribe members have differential access to. One respondent mentioned, but there has at times been a division in providing health care between our private sector, tribal, and IHS, which is the Indian Health Service. And it's widely known that it happens. Another reported, some people just refuse to even come to tribal health or IHS. They want to go to private providers because something happened here that they didn't like, and we don't have consistent providers at IHS. Another theme that actually might be a very interesting area of some additional research are really the importance of incentives and getting people to engage with public health plans or even their providers. At times, many felt that incentives were essential to actually getting people in the door. So here are some quotes on that. To get them there, or sometimes to get people to participate, you may have to offer an incentive. I hate to say that we are incentive-driven, but it is what may make a difference between somebody participating and somebody not participating. I look at it in 2 different ways. One, that we are incentive-driven, but we are also trying to survive. As I mentioned before, this is also an area of endemic poverty. And getting people to engage sometimes in preventative care, really incentives do help. Even for my own health care, there's an incentive of doing my own annual health review, and I get some credit towards my deductible. And I think that we see a lot of that also on the reservation. The next quote is, we kind of get into this rut where you have to either offer food or incentive. I shouldn't probably say a rut, but it seems like when we do have functions and we don't offer that, we're not getting as good of a turnout. And then maybe with our addictions and people on a fixed income coming to eat. But then also, in the Lakota culture alone, if you feed, then it is an honor. And that's another important thing to consider when there are those that are not as big of a fan of offering incentives, or they don't like the fact that people feel that folks are becoming dependent or expectant of these incentives. But also you're respecting culture as well. When you have a meal, that is something that really does sort of bring in a more sort of a cultural, it shows cultural awareness, and that's something that historically has been a way to get people to gather and to share information. Okay, so besides getting people together, I mentioned that this area is approximately the size of the state of Connecticut, and people live very, very far away from one another and healthcare. We also asked a lot of questions about communications and connectivity, but it is very limited and expensive on the reservation. One respondent mentioned, I have to drive 2 miles to go up to the internet. So we do have a hill that they call a cell phone hill, where you will see a lot of people parked and accessing. And if somebody's on a fixed income, because I can tell you right now, I personally have internet at my home, but I pay over $100 a month. So if they're on a fixed income, they are not getting it. So there's a lot of trouble with cell phone connection in many parts of the reservation, where people are actually driving a few miles up to get high enough where they're able to connect to a cell phone tower. And then those internet, I don't know about sort of the rest of the country, but right now in Texas, that's much more expensive internet than I have. As with many things when you're talking about implementing a program, and especially a new program, especially in a place where many programs have been attempted and perhaps haven't sustained themselves as well as persistence matters. But it has a bad track record, unfortunately, on a reservation. We have to be consistent, one respondent mentioned, because one of the biggest complaints is that we try to introduce something and then it never follows through. And we heard that sort of over and over again, especially in our focus groups with community members. Another important thing to consider is that the engagement strategies will differ depending on who you're trying to engage. The elders on the tribe are very, very well-respected individuals. They're also oftentimes taking care of their grandchildren in many cases. But they also engage differentially than other people do. As one respondent mentioned, they are a little bit private, and you really kind of have to listen to them to see what they're really trying to tell you. It's not always black and white. Sometimes you may have to hear what they are saying and then ask another question, and then ask another question to get a full answer. If you look at our culture historically, they are storytellers, and a lot of our elderly kind of are like that. They tell a story to get their point across, or they go a roundabout way to give you an answer. Our elders are probably still going to come to us at clinics or come to us personally because they like face-to-face interaction. Another theme that we discussed frequently, especially due to the geographic sort of dispersion of individuals across such a large area, outreach into communities. Our population here are a lot of hands-on. If you see a piece of paper like this, and they were referring to a handout about the Tasina Luta, and so I did not add that, and they don't understand it, then they will just push it to the side. A lot of visual, and if somebody talks about it, that would be the best. And then going to each district. That is maybe where the Community Health Representative Program and health education can help. Because the CHRs, the Community Health Representatives, they are responsible for different districts across the reservation. While many of them might be based in Eagle Butte, in sort of the center of the reservation, they are all sort of assigned to different districts, sort of northwest, north, northeast, all these numbered districts that they have across the reservation where they're supposed to be engaged frequently with, especially elderly, but really all individuals in different communities across the reservation. So every community within the reservation is supposed to have at least one CHR, and depending on sort of staff turnover, generally they try to make sure that, every community has somebody assigned to them. One of the pillars that I mentioned before was sort of these health handbooks, which is sort of like a hard copy version of WebMD, and hopefully one that doesn't, when friends of mine sometimes look at WebMD, they might overdiagnose horrible things. Whereas HealthWise handbooks are hopefully guides that are more helpful in getting people engaged with their own health and will help them know when they maybe should go seek additional medical attention, especially for a population that doesn't seek attention frequently or early enough. And so here was a respondent talking about how could we get people to actually engage with these HealthWise handbooks. And they said that our CHRs, again, are going to be a wonderful resource because they are already out in those communities. I don't see our younger generation having a problem with it because they are already used to Googling things if they have the means to do that. But it is going to be that generation that is maybe elderly, to almost elderly, that isn't as used to electronics or doesn't have it, or their limited income keeps them from having that. But once we get into those ages, then our CHRs are supposed to be targeting those homes anyway to do home visits. So I think they can be utilized a little bit more when they stop in. Pull it off the shelf. Do you have your HealthWise book? Do you have any questions about it? You know, sometimes, and this sort of goes back to one of the prior quotes where they're talking about just providing somebody with a piece of paper, they might just push it aside and never look at it. But if you actually try to engage with individuals, with the material, in a one-on-one situation, then that might actually encourage them to make more use of it, especially for the elderly population where they're really going to be looking more for the face-to-face interaction with people that they trust and know, which is also why the community health representatives are so essential. The theme was that communication methods have changed. One respondent mentioned that when I was a kid, we went on weekends on Saturday or Sunday afternoons. You would go and visit your neighbor and have coffee and play cards. You don't see as much of that anymore. It seems like people are too busy, or maybe because of social media, they value their privacy a little bit more. So it's not as acceptable anymore just to drop in on somebody. We don't gather like we did. So that is going to potentially limit some of the engagement that can be achieved through sort of face-to-face or word-of-mouth interactions. While it's still important especially within the elder population, that sort of social cohesion has maybe shifted a little bit. Another theme is that cultural awareness is the foundation of outreach. One thing that I should mention is that none of this work would have been possible had Kay and other researchers at A&M not have worked with the Cheyenne River Sioux Tribe for 12 years. Their building a relationship is very key. It's essential to working, especially with a level of academic humility and cultural humility, where there has been a lot of historically investigators and researchers potentially coming in and working with tribes but imposing their values and ideas upon tribes. Having a relationship where we were able to really try to gather information from tribe members and have their voice sort of come to the front, that's really what the whole focus of this research project has been. And it's a challenge. And this is one of the challenges that I had to learn about when I've lived in a few different situations where I've been an outsider before in my time. But here's one that I hadn't experienced before. So a respondent mentioned that he was talking about a Caucasian preacher, came right up to me and she was right in my face. And I was like, whoa, 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 you don't do that in our culture. And you don't try to match eye for eye. I'm comfortable with it off and on, but here it's taught as being very rude, that to really stare somebody right in the eye. And on the outside, they're saying you're not being honest because you're not looking me right in the eye. So it was while we were doing our focus group and our key stakeholder interviews, I noticed after meeting with this individual sort of a wide variety of comfort level with eye contact. And we did our best to try to mimic with whatever that comfort level was with the population that we were interviewing or working with at that time. But it was a challenge. That's something that I would not have known had we not gone out and spoken with some of these individuals and had them share with us this important information. Another thing that's related is approach and style matter, especially when trust has broken down with vulnerable groups. One respondent mentioned, I even did this exercise with some young people. I said, I'm going to walk through this door. Tell me when to stop whenever you're uncomfortable. There was a young lady in the corner over there, and I was about halfway step in, and she said stop. So that was her comfort zone. And with the male who is the ultimate gangster and I got 3 steps in and he said stop. And when asking the consensus of the room, where would you be at? They probably said in between those two. And this is an interaction, or this is a discussion about an interaction between tribe members, a respected tribal public health professional on the tribe, and some of the youth in the tribe. And there are problems with drugs and alcohol on the tribe, and there are a lot of communication breakdowns that can happen, and a lot of distrust even between tribe members. And I think that this was able to demonstrate that pretty well. Another theme, and I'm sorry I've read through so many quotes. I know you're not supposed to do that when you present, but this is qualitative research, so I'll take advantage of that. The importance of Medicaid was an important theme that came up a lot. South Dakota is a non-expansion state, but Bridger, which was on the southwest corner of the reservation, is much closer to health care in Phillip, which is off the reservation, about 45 minutes away, when Eagle Butte is 1.5 hours. 70-80% of Bridger have Medicaid, and they go to Phillip for care whenever they possibly can. But others have to go twice the distance because they don't have Medicaid. In some situations, they might actually just get straight to emergency departments in other towns off the reservations if it's something very serious. But when they do that, they have to hope that Indian Health Services might pay for that visit or that care retroactively. And that's a risk because what they go to seek care for isn't always covered. Or that was at least considered risky by tribesmen. Some other important themes, obviously transportation is a challenge for many, especially with the great distances. Having gas is sometimes a luxury. It's not affordable for many of the individuals on the reservation. So therefore, it also may be necessary to do annual health reviews in communities. Targeting those, of course, that are already engaged with their own health will be easier, and getting others, especially many of the folks that are over the age of 18, will be difficult. And another one that's sort of obvious is that social media is widely used among youth in the working class who have connectivity, but also the radio on the reservation reaches a much broader audience, and elders will communicate more face-to-face or at community events, as I had mentioned before. So that was just sort of a snippet of some of the findings that we have at this stage. Going forward, we need to still finalize our coding and our analysis of the many, many hours of interviews and focus groups that were conducted. We'll prepare a final report and a presentation for the Tribal Health Council coming up this September. We'll, of course, want to publish our results. And then also examine and determine some additional resources for really trying to help kickstart implementation efforts for this local autonomously developed public health plan. To really get going, it may need some additional funding that will hopefully be able to find. We're also very interested in pursuing research, testing out some of the different research and engagement strategies that have been recommended by all of those that we interview. There's radio, social media, flyers, community events, community health representatives, but then also really looking at the impact of incentives and different types of incentives that are used on the reservation. There's a long history of using incentives to get individuals engaged. And so as I mentioned before, for some that's a negative, for others it's just a necessity and a practicality. But to maybe do some research finding what the right incentives are for which types of programs might also be something that could be looked at in the future. All right. And with that, I think we will pass it over to Alexandra.
Actually, I'm just going to, this is Anna, and I'm just going to interrupt very briefly to do an introduction. But first I want to thank you, David, for that excellent presentation, and thank you and the audience alike for your patience with the technical glitches in audio there at the beginning of the call. Hopefully we have that under control now. And it is my privilege and pleasure to introduce your commentator for today, who's going to respond to some of what David has shared, and that is Alexandra Little. Alexandra graduated from the University of South Dakota in 2012 with a Bachelor of Business Administration with a major in Health Services Administration. She currently works as the Hospital Preparedness Program Coordinator for the South Dakota Department of Health in the Office of Public Health Preparedness and Response. Part of Alexandra's duties include coalition building and providing preparedness support to healthcare entities across the state of South Dakota. She's currently working toward her Master of Science in Administration with an emphasis in Health Services Administration. So Alexandra, please take it away.
Great, thank you so much. Like she said, I'm Alexandra, and I'm the Hospital Preparedness Program Coordinator. And some of my additional duties that were not mentioned is I also help include, part of my duties include building relationships and partnerships with tribes in South Dakota. To date, the South Dakota Department of Health and Texas A&M University has collaborated with 6 of the Sioux tribes in South Dakota to help work with some of these public health challenges like David mentioned today. Just to kind of wrap up and tie up his presentation, I just had a few additional comments that I wanted to share with you to get you thinking about some different things. So a couple of years ago, there was a TB outbreak on the Cheyenne River Sioux Tribe, and some of the challenges occurred, and primarily you'll see this in all sorts of incidents, that the biggest issue is always that communication or lack of communication or miscommunication. And so the biggest thing, with that TB outbreak was which agencies do what, who's responsible for what. So what does Tribal Health do, what does Indian Health Services do, and what is the responsibility of the Department of Health? And then another question to pose there is whose jurisdiction is it in, and is who covers it? Is it Tribal Health? Does South Dakota Department of Health have authority over that? So those are some of the challenges that we see in those types of different outbreaks. And another thing I wanted to be able to touch on today is some of the key factors for a successful public health investigation during an outbreak, and maybe some of the factors that helped, what I think helped during the Yankton Sioux Tribe salmonella outbreak. Being able to have common goals and recognition of the jurisdictional sovereignty. And then, like I said before, that coordination is key. Getting the tribal health directors and IHS and the state to be able to work together. Having those relationships built prior to an incident or an outbreak. The saying goes, you don't want to be handing out business cards at the disaster or incident. You need to be making those relationships prior. So when that event occurs, you already have made that relationship and can make a quick phone call or send a text message or email and don't have to make that introduction. You already have that relationship formed. And then communication is key, whether that be by phone call, email, having our state epidemiologist in communication with what's going on, being able to receive those monthly reports, being on our EPI listserv and our Health Alert Network for communication. Moving forward, I look forward to continuing to work with the tribes on public health preparedness. The tribal health directors are now starting to get involved in our regional healthcare coalitions. As of the past month, I've reached out to them, and that will be able to help them to be able to share different resources to bring back to the tribe and the reservation and help bring those relationships, build those relationships. My personal goal is to be able to help build those relationships so we can all work together to better prepare for and respond to public health crises in our communities. Thank you for allowing me to speak today. Are there any questions? I think this is the time where we're going to open it up for that.
Yes, thanks so much, Alexandra. I think we already do have a number of very good questions lining up, and many of them have to do with the conduct of community-based participatory research and the kinds of partnerships that are required to drive it. And I know that everyone would like to hear from both of you on these kinds of issues. So with each question I throw out, I'd like to hear from both of you. Perhaps first from Alexandra as sort of boots on the ground there in South Dakota, and then from David, if that's possible. So the first question that has really rolled in here is that sustainability is an issue with these kinds of projects and programs. So how involved are the tribal leaders in this work, in both the research and the practice elements?
Yes, I can speak to that. So that is a major challenge, and that's something I should have probably touched on. So one of the challenges we do face is the tribal leadership. They do overturn and have elections every 2 years. So once you get in and build that relationship, you kind of get things going, and then everything kind of switches. So I think just being able to pass on that communication and have good documentation and just continue to build those relationships with those people so then they can maybe pass on some of those things, the good experiences that they've had working with myself at the Department of Health or Kay, that they're able to help have a clean transition during that time.
And I would just add that with those sort of with those transitions of leadership, sometimes they affect sort of the very top level, but sometimes they actually spread down. People bring other folks that they know sort of with them into. But it's also the case that many individuals who may not be level leaders, who are both advisors and positions a level or two below that, who are engaged with public health on the region, at least the Cheyenne River Sioux Tribe, have been sort of consistent over a long time. So it's key not to engage with the very top leaders, but also with sort of mid-level leaders to make sure that those folks that may actually stay and continue and have longevity are really leading the charge more than just other folks that might be a little bit more political. Because politics, they are a challenge.
Thanks, David. I'm going to interject a moderator's privilege question here related to the methodology. I noticed, one of the themes I sort of detected in some of the quotes you were sharing was a lot of rhetoric directed at them and they, particularly intergenerational rhetoric directed at them and they. So you had people saying of the elderly, they do this, they do that, and people saying of children, well, they do this and they do that, or younger generations, they do this. Which leads me to a question about the sampling strategy for these interviews. I know you said you spoke with a lot of community leaders, but I'm wondering what the age range was in there and to what extent, say, youth shared their own insights about their experience of public health and community, or the elderly shared their own insights of public health and community rather than just sort of talking across at each other.
Sure. Great question. So for many of the key stakeholder interviews, those are individuals who are perhaps at some level of either mid or higher level leadership on the reservation, and many of them are more middle-aged to sort of somewhat elderly, of course, because youth aren't going to be in those positions. In the focus group, potentially there was a little bit more diversity. There were some more elders, but we weren't able to sort of purposefully sample as many elders or youth as we would have liked. So it's interesting. It's good that you caught that. But it's getting the elders engaged, I think, also requires some additional level of assistance. Something that community health representatives really are the right people to engage with that population, more than we could with our sort of limited ability to be for the interviews as we would like to conduct.
Yes, I completely understand. I'm just wondering, thinking about the sustainability issue that was raised in the first question, if there are opportunities for train-the-trainer types of exercises in research methods that would allow perhaps those CHRs to lead focus groups or interviews with elderly or younger populations. Just throwing that out there as an idea. Obviously,
absolutely.
It is outside the scope of this. It's outside the scope of this project, but it's something that in the future it might be worth considering.
Absolutely.
Moving on.
And we've actually, and that's discussed. I'm glad to be picked up on that, because the community health representatives, with engagement into the community, and also their engagement sort of with a diverse group of, and also being folks that are trusted the populations that they work with. Not all community health representatives speak Lakota, but some do. And so that is, greater engagement between community health representatives and the communities themselves is definitely an area that we should explore going forward.
Terrific. Thank you so much, David. We have a couple questions, and I do want to note, I'm not sure if everyone is hearing it, but I'm starting to have some of the similar technical issues hearing David as I did at the beginning of the call. So if our Ready Talk representative on the line could please be checking into that. In the meantime, we'll kick out a couple of questions that I think are probably geared more towards Alexandra, and then welcome David to weigh in as well. But the first one is whether the tribal entity has a public health structure, or if the Tribal Health Board really leads the public health plan. And I feel that you both probably can speak to that, but we'll begin with Alexandra.
I can speak to that, yes. So what we've kind of been doing with, I can speak to specifically for the Sisseton-Oakte tribe. And what we've been helping them with as far as the public health structure is working on a COOP and recovery plan. You know, how are we getting a continuity of operations plan in place? So that's kind of what Kay and I go in and do. We go in and help with certain specific plans, and I wish she could speak right now because she could probably speak a little more in detail on this particular question, as I'm just getting trained up on all of this and trying to learn all the past history. So I'm probably just going to pass the rest of this back on to David.
Sure. Well, on the Cheyenne River Sioux Tribe, it's really sort of both are involved. So the Tribal Health Board, as I mentioned, Peggy Badwarrior, Margaret Badwarrior, was responsible for sort of developing and writing up the public health plan that was signed off by the Tribal Health Council, as it's called there. So that board is sort of at the leadership level very seriously involved. But tribal health also, that includes all of the community health representatives. That includes all of the clinics that are out sort of in the communities. So both are essential components of being able to push the Tasina Luta forward.
Thank you both so much for those terrific insights into the ways in which public health operates with this tribe. We also have some questions, again, that Alexandra may be the logical first point of contact for this, and then David, please come right in. The question is that with the mention of outbreaks, to what extent CDC has been involved in this? Because the questioner notes that once IHS is contacted, they connect with CDC, who should be the lead for public health outbreaks, crisis, and preparedness. And IHS simply does not have the resources and expertise to handle outbreaks, emergency response, et cetera. So I know sitting there in the state, Alexandra, you probably have some important insights on this comment.
Absolutely. So like I mentioned before, communication is key, and being able to get, if there is suspicion of an outbreak, being able to get in contact with the State Department of Health. South Dakota is unique in that we don't have local health departments. We just have the one in the city health department in Sioux Falls area, and then the rest of the state is the state health department where we have community health offices. So when there is an outbreak, connecting with the South Dakota Department of Health, who then has disease intervention specialists that are able to work through those outbreaks. They are able to then work with our state epidemiologist, and he is the one that would be having some of that contact between CDC and then relaying that information back down. So IHS coming to the State Department of Health, and then that kind of filters up that way. Does that help answer that question?
I think so, and I'd also just point out that really preparedness, whoever is the lead on preparedness, it is such a multi-sectoral enterprise with even private, particularly in an outbreak, there are opportunities for private business and industry to support preparedness efforts by, for example, social distancing activities related to telecommuting, asking employees to work from home until the outbreak has passed, or other kinds of issues. So whoever may be the lead on a specific issue, it's important for everybody to be able to work together, so those lines of communication really have to stay open. And I imagine it's a lot of the work you're engaged with, Alexandra. And I know A&M has been working a lot with the tribe on preparedness issues. So just to ask David if he has anything to add.
Nope. I'm trying to cover that one pretty well. Nothing to add. Great,
thank you. Well, we have another question. thanks for sharing this great work. To what extent are nutritional and food security needs addressed through tribal public health efforts? I'm not sure who's the best person to take the lead on that one.
I don't think I have anything to add on that one. David, do you?
So not too much. This particular program isn't really focused on nutrition at this time. And so as this is sort of it's sort of an initial effort to sort of build a tribal public health structure that hopefully things will be able to be added onto it going forward. That's not to say that there aren't other nutrition programs. It's just not part of this particular program at this time.
Terrific. Thank you so much for answering the nutritional and food security question there. I have another question that is related somewhat to the methodology of CBPR. I asked one a bit earlier, and then I have another. As a community-based and community engaged and stakeholder engaged and that whole spectrum researcher myself, I know that I sometimes find it quite challenging to manage research projects that are just 3-4 hours down the road. So I'm curious as to how this partnership has developed and sustained, and how exactly logistically you all have gone about the work of building and maintaining such an important partnership to help us build knowledge about what is working in this instance and what can be improved in the future.
Really, the best person to answer that question would be Kate Carpenter, since has been working with the tribe for over a decade. But it's, and hopefully I won't speak, but the continuation of effort, really building relationships over time, patiently, I think has been essential. It has built a level of credibility where even at distance, there is communication via email, over phone. Sometimes during some periods, I know Kay is having weekly conversations with different tribe members, and it's a challenge. Distance makes things more difficult. But that's the lead-in. Every single one of the focus groups is an introduction by a very well-known tribe member that researchers have worked with for years and years. And that sort of introduction and credibility was only possible because of that relationship over time. And so there are definitely logistical challenges to being so, even as you mentioned, 3 to 4 hours away, living within the community would maybe be the best way to actually do really effective CBPR, but that's logistically feasible. Are so far away, and they're even when you're on the reservation, traveling from one town to another can take 2 hours, 2.5 hours. I think patience is key, persistence is key, and making sure that you focus on building that relationship, which is something Alexandra also mentioned, sort of from the beginning. And building that trust is just really essential.
Absolutely, and I'd like to piggyback off that. Like David said, the distance between tribes is pretty significant. So when Kay comes here, she does spend a lot of time on the road. We just had a trip last month. So a key to building those relationships, what Kay and myself like to do, is get out there and have an in-person meeting for that first meeting, just to be able to start building that trust and relationship. So although it may take a lot more time to do that, I think it puts us leaps and bounds ahead versus of just trying to have a conference call.
Well, thank you both. And I think that you have made some really important points about the importance of building trust early in the process, which is a critical piece of even getting your foot in the door for CBPR, is establishing those relationships and building that trust, and that does not happen overnight. And I think that this particular project has been a terrific example of the fact that Systems for Action has a variety of methodological approaches that can range from data analysis to CBPR in communities. And I think that there is room for all of that kind of work in this program, because sometimes I once heard one of our funded investigators a few years ago say, you know, the numbers can tell us the what, but they can't tell us the why. So you all are doing a lot of important work right now to figure out the why ahead of the game, why this program is successful or why this program encounters the problems that it might encounter, and how to begin solving those kinds of issues. So I think that that's really exciting. And we just had one additional question come in. So before we wrap up, I do want to give this person an opportunity to ask this question, which is, what journals, and this is an important question for engaged research and particularly engaged tribal research, what journals do you recommend to share our experiences at tribal health departments developing frameworks and approaches to system strengthening?
Well, the challenge is sometimes publishing qualitative research is difficult. Well, I agree. Figuring out the why and the how. I think any type of is very knowing what to ask. Easier if you've already gone qualitative research. So there are qualitative focused journals out there I think are interested in this type of work. I think also, there's a lot of community health journals that are interested in this type of work. Some of the more practice-based journals, I think, tend to publish more qualitative CBPR type work. So there are just because it isn't as actually published of an area as you find with most survey work or with sort of big data sets. But I think it is extremely important because it does allow us to ask the questions of sort of how and why well before we're even potentially designing the surveys for additional work in the future. And it's also,
thanks, David.
And it's also just, especially with vulnerable populations, it's very important to provide a voice. And that is much harder to do when you're just going out and asking questions and collecting the data that are numbers and not asking questions like why and how. And it specialized sort of historically. It also is, I think it's respectful to start with qualitative work, and especially CBPR type work.
Thank you, David. You're exactly right. There are qualitative focused journals. There are practice-based journals. There are community-engaged and community-based research journals that you can often find. I would also note, though, that for this kind of work, it is also just as important, and I know for those of us on the tenure track or in academic worlds, that publication in a peer-reviewed journal is really important for our own personal lives, but for really disseminating and spreading this kind of work and helping folks recognize what's working and what isn't. There are other kinds of communications that are equally important for those in the field. It may be conference presentations at different places where the right people are going to be to help spread the word about what you're learning. It may be webinars like this one. It may be research briefs that get disseminated among the right organizations. So you really have to think through when you're doing this kind of research, who is the audience? Where can I really move the needle? And while we obviously have to publish in peer-reviewed journals, those of us in academia, to really have an impact in the real world requires us to reach beyond those kinds of traditional communication methods. So again, I want to thank David and Alexandra for their terrific discussion today of this important work. We look forward to continuing to follow this along, and we'll have you both back in a few months to tell us what you've learned through this project, and we're excited to hear about that at that point. I would invite those of you on this call to have a look at our upcoming webinars. if you're new to this webinar series, and see if anything here interests you or intersects with the work that you are doing. We would welcome you on any call. We also have these webinars are archived on the Systems for Action website, so if you want to look through the last couple of years of research webinars we have hosted, we invite you to do that. If you have any questions, please do not hesitate to contact us. Spend a little time at our website, and again, we want to thank the Robert Wood Johnson Foundation for supporting this important research program, and we look forward to hearing from you all soon. Have a terrific day. Thank you.